So I have something big to share with you guys, but you've got to wait to the end of the video to see. Hey babes, welcome back. Okay, listen, I know it's been a long time. I just had to take a little bit of a break to just reconnect with my mental and get life straightened out. So I'm sorry that it's been a while, but I'm back and thank you for staying with me. If you haven't already and you're new here, please like and subscribe. I would always love to have you join my lovely team of babes. So let's get to the video. So I have been getting a bunch of questions and just wondering where I'm at with cardiology and how that's going as a new grad in my new grad year. So this video is going to be all about that. Okay, so I'd first like to start off by going over a couple of the questions that I've gotten on my last cardiology video. And one of them is, so it was a nurse asking me if I can go more in depth about cardiology and what the work life is while working on a cardiology unit. So I will say my schedule is like 3 days a week, typically 3 12s a week. I work 7 a.m. to 7 p.m. and then I usually don't like to work all 3 clumped together, so I'll work like 2 in a row, have a day or 2 off, and then I'll work the 3rd or whatever the case is. For me, at my particular location, we are every 3rd weekend, which is kind of nice so that I'm not working every other weekend. But in the aspect of cardiology, oh, where do I begin? It's definitely something that takes some practice and getting used to, because there's a lot of things that are just specialty like, which is just things that are just particularly to that particular specialty. And cardiology is one of those. So thankfully what my unit has and my hospital has, they have a thing called cardiac core. And cardiac core is when you go and you learn about all of these special tests that your patients go for, all these procedures that they have, and then tests that that they need leading up to these procedures and things like that. So in that sense, it really helps us out and allows us to really know what tests and procedures our patients are going for, so that when your patient is going for it, 1, you know what they're doing and why it's happening, and 2, so that you're able to explain to that patient on what tests they're going for. Because how silly would it look if you walk into a room and say, hey, listen, you're going down for a stress test today, and you have no idea what it is, and they ask you and you just don't know. So thankfully, again, we have a thing called cardiac core. They teach us all about that. We look at heart rhythms. Before I even was able to come to work, I actually had to take a EKG class, which really helps because all day we're reading EKGs. We have to be able to read EKGs. So in a sense, that helps you prepare for when you do start on the floor. Now I will say that just looking at a normal rhythm on paper is not the same as looking at a rhythm on the screen in real life, because real life is not just P, Q, or ST. Real life is not as just picture perfect as it is on in a notebook or online when you go look up a picture. So it helps you prepare, but I will say it does take some time to get to a point where you're comfortable reading EKGs and things like that. I feel like since the last video, which was, I think it was only like 3 months in cardiology, now I'm just about a year, I've come a long way, very long way. I wouldn't say I'm fully comfortable, because what nurse of 1 year is fully comfortable? But I will say is that I'm starting to develop a routine, which is nice, because I start to be able to just answer more questions by myself than I would be able to before, or just be able to think of things logically and understand why they're happening, and explain it to my patient on why they're taking this med, or that this med, is usually used in another population, but we use it for you because of blah, blah, blah. So those things are very nice to be able to develop over your time, because you actually feel like you're learning something, and you are. I swear to you, I learn new things every single day, and it's a field where you never stop learning. You never stop learning, and don't be afraid to ask questions. I swear I ask so many questions a day. I even ask questions to the providers, to the doctors, to the APRNs. I ask questions because I don't know it all. And the most dangerous person is a person who thinks they know it all and they don't. So don't be afraid to ask questions. Don't be afraid to ask questions to even the doctors or the providers. Why are we doing this? Why is this patient, why did we choose to not give this patient Lasix, but we chose to give this patient? You know, things like that. Just in general, if you have a question about it, I always ask. And that's another thing. So especially with cardiology, I feel like you have to be very close in contact with your doctors, because you can have a patient who's stable at one moment and then all of a sudden they go into these weird rhythms, or they start to develop just a bunch of symptoms that they didn't previously have, and you have to be able to communicate to your doctor these changes. So it's very good to have a good relationship with your doctors and create good relationships, okay? And I think once you create those good relationships, them as the provider start to trust you more. They start to trust you, and they say like, look, this nurse knows what she's doing. She has the best interest of my patient in mind. So that's always a good way to go. You want to be able to just advocate for your patients and ask the right questions, and just don't be afraid to reach out to the provider and say, look, you know, I'm not too sure about this patient. Can you come take a look at them? Because they're being kind of funny. They look a little bit different from before. Whatever the case is. And some providers may give you pushback, but I get to the point where, like, listen, I don't care. If my patient does not seem the same, I'm going to ask you to come and take a look at them, because if they're declining, chances are they're going to decline very quickly, especially when it comes to cardiology. So just don't be afraid to reach out, and don't be afraid to really stick up for how you feel, or ask the questions to gain understanding about your patient and why we're doing this, you know, for a patient. There's a lot of times where I have to reach out to a provider and say, hey, what's our plan of care for this patient? Like, what are we doing? Because there's some days where, like, the patient's just sitting there, and I look back, there's no notes. They didn't put a note on the patient after seeing them that morning, and I'm like, what are we doing? Like, what is going on? And then sometimes they'll say X, Y, and Z, and this is how we move forward. And the other times they just don't know, because of whatever the case is. The patient may be complicated. They still may be waiting on certain test results and things like that. So a couple of important things when working in cardiology, like on my daily basis, that like I'll check and I'll keep an eye out, is electrolytes. The first thing I do when I am looking at a patient's chart in the morning, I'll look and see if their morning labs are back. And then I'll look at their electrolytes, because we know that potassium and magnesium are electrolytes that are closely aligned with the heart's function. Okay, so if those levels are off in any kind of way, it leads to the possibility of a patient going to a lethal arrhythmia. So potassium and our cardiology, we like to see that at 4 and above. And then magnesium, we like to see that at 2 and above. So once the patient is below those numbers, I'll reach out to the provider and say, hey, look, the patient's potassium is 3.8. Would you like to replace? And most of the time, they'll just put in an order for potassium. Or the patient's magnesium is 1.3, which is really low. I don't think I've seen a patient that low. But anyway, I'll reach out to the provider and say, hey, look, the patient's potassium is so-and-so, or the patient's magnesium is so-and-so. Would you like to replace? And then they'll throw in an order for that. And then I'll explain it to the patient, like, look, listen, like this, they'll wonder why they're getting all these different supplements, blah, blah, blah. I'll just explain that to him. Like, listen, this medication is closely aligned to your heart function. It's really important that we replace it so that we can keep your heart under control. Another big thing I look out for is their kidney function, because a lot of the medications that we give our patients, because they're heart failure and CHF patients, is diuretics, IV diuretics, and even just some of the heart failure drugs like Jardiance, which is actually a type 2 diabetic medication that they're using for heart failure patients. Those are nephrotoxic. So it really affects their kidney function. So if they already have a low kidney function and we're slamming this Lasix into them daily, multiple times a day, it could actually cause their kidneys to not function so well, and their kidney function levels will increase, which is not good. So I'll usually check the kidney functions before I walk into the room. If their creatinine is like 1.3 creeping up, keep going up, I'll let the doctor know, say, look, this patient's creatinine is blah, 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 blah. Would you like to hold Lasix for today? Or would you like to hold whatever other medications that they're on that are causing the kidney to kind of just not function as well. Another thing is a lot of our patients are on medications that affect their blood pressure. So although they're on a medication that affect their blood pressure, sometimes you still want them to get their blood pressure medications. So I'll see a patient with a blood pressure of 100 or a little bit below, and that's okay. The doctor will still want to give them their medication because they need the medication for their heart function. So you just always, again, want to be close in contact with the doctor and be able to ask them, like, listen, patient's blood pressure is 100 over whatever, or 98 over, do you still want to give this medication? Sometimes they'll say yes, sometimes they say no. And then you'll find your little frilly that they're giving hydralazine, which happened to me. Her blood pressure was like a little over 100, it was like 103 over whatever. They were continuing to give this lady hydralazine. Gave her hydralazine, and I come back in later and she's like super lethargic. I ended up having to call like a rapid on her. But it really just depends. So a lot of these patients, blood pressures are on the soft side, and you'll have some who are really on the high side. So it's all about managing those and continue to monitor them. When you get a patient with chest pain, and first thing you always do, at least for us, was we do an EKG. We let the doctor know. The doctor may want to give them nitroglycerin. However, you can't always give somebody nitroglycerin because they may have a valvular issue. If they have a valve problem, nitroglycerin probably isn't best for them. So there's just a lot of thinking that has to go into your actions for the day that you get over time. And you can't expect yourself to have that when you go into cardiology right away, because gosh, I did not have that critical thinking, and I'm still not the best at it now. I still ask questions to my senior nurses. I'm like, listen, this patient is having chest pain or having this issue. Help, what should I do? Or I'll get a patient that comes back from the cath lab. What happened to me the other day with like a TR band, they had like a hematoma, but then I had to cover it, and it was just a whole situation that I just wasn't sure how to go about it. So I went and asked my senior nurse, like, listen, what do? I need help. There's just a lot of things that you will end up growing into and being able to, I would say, critically think a lot better as time goes, which has helped me a lot by asking questions. Because when I have that experience, again, I'm able to, be able to deal with that situation from experience of having another patient that has had that issue that I asked the question about, and now I know what to do. So definitely don't be afraid, because I know that it's tough in the beginning. In the beginning, you just feel uncomfortable and you don't know if all the actions you're doing are right actions. You just, at least for me, I was afraid of making the wrong action and it hurting the patient. And I would constantly just be afraid to go to work and afraid to leave work because I'm afraid I didn't document something that I should have documented, or just anything. So just know that it comes with time. You will get there. Again, I'm just about a year in and I'm still not completely there. I'm still not completely comfortable when I'm doing a lot of my tasks, but I definitely feel like I have a good basis of knowledge to feel like I am getting there and that I am growing and progressing. When you feel like you're growing and progressing, I swear it's the nicest thing ever. I mean, patients come in with all different types of things. And you just want to make sure that you know what, when you walk in the beginning of the day, that you know what heart rhythm that your patient is in, and you're able to identify the rhythm, because they can very quickly switch into a rhythm, sometimes without you knowing and sometimes without the receptionist knowing. So you can go back later and look and they're not in the same rhythm that you left them in this morning. So it's really good to really know what rhythm your patient is, and not just from report and the previous nurse saying the patient is in this rhythm. Like, no, you want to, great, get that report, and then you want to go look at their heart monitor and make sure that patient is in that rhythm. Because I could get a patient who has a history of AFib, the nurse tells, and they did convert to normal sinus, so currently they were in normal sinus, The nurse from night shift tells you that they're normal sinus, and then you go look at the monitor and they're an AFib. They do have a history of it, but it's a new rhythm for them in the current situation. So it's good for you to know that they switch back to AFib, because that also means that this person needs to be on a blood thinner, you know. So things like that you just want to pay a lot of attention to, because remember, it is a tele unit, it's a cardiology unit, so that's very important for you to know what rhythm your patient is. Other important things are when you're traveling off the floor, most of our patients are on heart monitors because they're cardiac patients. So when they travel off the floor, you have to travel with them because you're responsible for them. You're making sure that their heart's not going into lethal arrhythmia, that they're not decompensating while you're away. So time management is very big, because you have to be able to go take your patient for this echo or take your patient for this x-ray or CT scan and still be able to manage the rest of your assignment, and being off the floor for a half hour and still be able to come back and manage the to-dos for the rest of your assignment. So time management is key, I will say. And there's days where you feel like your time is slipping away from you, and it's okay to ask for help from a coworker. Hey, I'm going off the floor for this test. Do you mind giving my patients their insulin? Or do you mind giving them their 12 o'clock meds while I run off the floor? Because sometimes, you know, I like to make sure that I can get my patient to these appointments so that they can get out of the hospital sooner. Because it comes a lot of times where you're not able to go to these appointments, but now it's pushing, you know, those tests back later, so that the patient isn't able to go for those appointments, and then they ultimately aren't able to get the answers that they need. So then it's just a delay in patient care. So I really try my best when a patient needs a test and I have to travel with them, is to make time to travel, because I know how important. Now, if there are some cases where you just can't. There's some cases where I have a patient that's decompensating in room 24, and I just can't leave the floor because that patient is not stable. So it does happen. Don't beat yourself up over it, but just do your best to try to just provide the best care for your patient, because again, they need those tests to figure out what's going on with them. Other things in cardiology is heparin drips. We get a lot of people on heparin drips because it's a blood thinner, and a lot of them are coming in with heart attacks and things like that, and need stents placed. And making sure that you're on top of those, and you know why they're on this heparin drip, why they're on a blood thinner, why they may not be on a blood thinner, and should they be on a blood thinner? Should you ask the doctor why they aren't? Maybe the doctor isn't aware and you just caused, you know, a mistake. So things like that are very important. I will say that my hospital is a level 1 trauma center, so days get hectic. My floor is hectic. Sometimes people hate floating to my unit because it's so crazy. Sometimes the workload is just a lot, and some days are very overwhelming and you're just ready to go and not come back again. How many times do I say when I leave, oh, I'm never coming back, and I'm back the next day? But there are plenty days that happens. Again, it's like a revolving door. Once one's in, once one leaves, the next one's in. As soon as you get a discharge, you're getting an admission. It's just being pulled, just like this all day. Sometimes it feels like you're just completing tasks, like you're just chasing orders. And that's just the reality of it. That's part of the job. And it's part of what we do. Again, there's days where I'm like, I'm not coming back tomorrow. Yeah, I will not be here because today sucked. So that definitely does happen more days than I'd like to admit. But I will say, I do think a lot of it is due to COVID. A lot of it is, I feel like patients are coming to us sicker than they used to be, because of COVID, and because of them waiting longer to come in because of COVID. So I think COVID itself has changed a lot of how we practice and a lot of our patients, because a lot of them are coming in sicker. Some of them are younger than what we're used to because of COVID. So I will say it does get hectic, it gets crazy, It's very fast paced, at least my unit is, and we're constantly on the go, constantly on the move, and that's just kind of how that goes. So yeah, I just wanted to throw that in there and make sure I said that, because it's not a cakewalk. It's really not. But then there are days that you have patients who really appreciate you, and those days are the days that make it worth it. Patients who tell your manager how lovely you are and how much of a difference that you made in their life. Those are the days that become very important and just show that you're doing it for a reason. I think I had one more question. Okay, so a question was, as far as learning the terminology, how did you do that? Did you have a lot of studying or reviewing med disease processes on your own? So, no. So what I did when I first started, I would, like, say I had a question about something, or something came up to where I'm like, what is that? Or, I really need to look further into that. I had a black book that I carried with me always. And in that book, whatever came up, I would write it down and I would go look it up later. I would ask somebody about it later. So I didn't really study, but when things came up that I wasn't sure about, I would go ask for it. In terminology and things like that, you will quickly gain. Oh, sorry, my camera died. So, what was I saying? Terminology. So yes, that definitely comes with time. And there are gonna be a lot of times you feel silly for like saying certain things because you just don't know the terminology. But you learn, and you learn fairly quickly. Again, like I would look things up if I didn't know, or if I'm reading like something in a provider's note that I just don't know what it is, I'll go and look it up. So you definitely have the time and opportunity to look things up. And again, a lot of the main like things in terminology, they'll develop over time, as well as for us, we had a class that pretty much laid all that out for us. So that was really nice. I would just say the biggest thing is don't be scared. Like, just dive right in, and I swear you'll be fine. You know, practice safe, practice confident, but don't be afraid to ask questions. And really, that's it. That's how it's going. Exciting news for me that I want to leave for the end is that I am actually now leaving cardiology. And those of you who've been following me know that my lifelong goal is to be a midwife. So I actually was able to land a position on labor and delivery at my hospital. So I will be switching over this week to labor and delivery. I will be switching to night shifts, so there will be videos on that coming once I get to that. And I also got accepted to midwifery school. So a lot has been happening, a lot to prepare for. So that has been one of my biggest, you know, just accomplishments the last couple months, is getting accepted into school and transferring over to labor and delivery. So yes, that's kind of half of the reason why just I haven't been around. The other half is just my mental space. So I am happy to share these experiences with you guys. I am glad you keep coming back for more. Don't forget to hit that subscribe if you haven't, and you want to see more. Ask me questions, give me all the love, whatever it is. And I will see you guys next time.